we look at rib lesions now, there's a number of different ways the rib can sublux. It can sublux forwards, it can sublux backwards. We're going to use a technique that really doesn't discriminate between the two. It's a distraction technique for the costotransverse joints. So whether this is sublux forwards or backwards makes no difference. The thrust should correct either of them. The best way I can show you this is actually on the spine. Now with the rib coming off of the vertebra, like so, and articulating with that transverse process, what I'm going to do is I'm going to put my digit so that either the tip of the thumb comes up against the tip of the transverse process there, and then the proximal phalanx comes along the shaft of the rib there. Okay, now when I roll the patient supine and I thrust back this way, it will drive the vertebra backwards while the thumb, the digit, holds the rib forwards, and that will distract that costotransverse joint. I can do it that way, or I can accomplish exactly the same thing by putting the knuckle tip against the tip of the transverse process and using the proximal phalanx as a stabilizer of the rib. So it sits like so. Now the rib now will be sitting along the proximal phalanx. The same thing, when I thrust down, it will drive the transverse process away from the rib. If I show you a mark with Mark laying prone, and this is obviously not the way we're going to do it, but it may give you an idea of what we're going to try and do. The hand will be in that position there, okay? So that the proximal phalanx is well supported on that, the metacarpal head, the second metacarpal head. You can put something in there between them, cloth or anything you like, to bring the thumb out a little bit further, particularly if your thenar eminence is really large, but you can do that with it. So the thumb will go, using this particular technique, along the rib and up snug against the tip of the transverse process, and the hand will close over it like so. Now if you can imagine Mark laying on his back rather than on his front, when I from the front push through, it's the same effect as me doing that on the rib and thrusting the rib forward, but it's a relative anterior thrust because it's actually the vertebra that will move backwards. The alternative way of doing it is like so, using that part of it along against the tip that way, hands in exactly the same position there. The only thing that differs really is with the patient supine in that position is that my arm is adducted to my side for this technique, where it is abducted, immediately rotated for the other technique. Now, below the scapula you can use either. Once you get up high, we've got the same problem we had with the flexion extension manipulations. That is, the scapulae tend to get in the way. So I find for myself that I always end up going to this particular technique using the tip of the thumb against the tip of the transverse process, and that allows me to keep the arm parallel with the spine. Lie on your back. So let's pick a mid-thoracic one to do. It's going to be on the left. Patient's arms go across their chest. And using this first technique, I'll come along the rib to the tip of the transverse process there. The arms running parallel with the spine. I'll roll him onto my hand and again lift him up. Now there's no side flexion, but fiddle around again until you get the infill that you want, and then drop straight down to produce that distraction. The alternative is to have the arm outwards more, so that now we've got that part of the thumb against the transverse process rather than the tip of the thumb. There. Again, roll back, lift him onto your thumb, find the infill, and drop down. As I say, it really doesn't matter whether you're doing an anterior or a posterior subluxation or a superior or a caudal, whatever you happen to feel your biomechanics tell you it is, this technique should, because it's distraction, get any and all of them.